When they have them on the wall, they will call us, come and bring bad news. In that palliative care, that was where we started. So if you look at this, at last contemporary country, they are sending messages. And these are real situations. You can see a doctor and a patient. You know what the doctor is saying there? There is no way I can tell you this. I'm sending you to someone who can, so they pass the report. It happens a lot in this environment. Can you imagine go to palliative medicine for you to hear what you want to say? But every one of us must have it. It makes you a better doctor. It even improves your relationship with other people. When I was doing my undergraduate diploma in medical education, my opinion in South Africa, and I always work in I was in the military in Cape Town. And first in the morning, we arrive at ICU at 7 o'clock. By the time you finish what you are going to meet here. If I meet at 12 o'clock, then you go to the work, you know. People are very hard working, only Nigeria that people are very big. Everywhere people are very hard working. And I will see communication in ICU. You can imagine how tough communication in ICU will be for patient to patient and the family. And you can't believe it. You will see house officers, resident doctors, doing this thing like a consultant. One day. And I look back at Nigeria. Able to communicate among ourselves interdisciplinary is even difficult for me. So it's only explanation like this that we learn it. And in this way, they pass the ball initially. Now they don't pass the ball. They do it themselves. Do they do it well? That's the question. So that one I'm done. I wanted to show you that. I didn't tell you that. You can see, there are so many difficult conversations between patients and the family. And some people just want to roll it away because they don't have the skill. You are not trained to do it. So that's part of the decision we made ourselves. Yes. There is what we call elephant in the room. Because you continue to ask, can the room contain elephant? But when you have something that is big, that is hiding, that is supposed to expose, but you find it difficult to expose. So you can see that doctor has something to do. But there is this thing in the corner, they don't know how to read. And the news is that he said, I'm hiding here in the room, and no one even acknowledge me. They will not even be source. That's better. That's another elephant in the room. Everybody is doing fine. I see that patient in wheelchair, but there are some things we need. And it's a typical case of hospice. I will encourage you people to visit hospices. It's still better to visit a good hospice. We have partnership with about 2 different hospices. We do there. We go inside to see how we do it before we can enact. It's not that we are doing now when I got to UK, I said, okay, I went for one interview. They know you are very good in Nigeria. You know you have a CV all over the world, but you don't have good system. When I brought up certificate for them, certificate almost 10 certificates in UK. But one of the certificates are St. Hospice, London. This is number one we are talking yesterday. And my first certificate at St. Hospice, London was in 2008. And that's the mecca of hospice. You have the opportunity to go there. And you are looking at the 2019. Where are they? Who will that do? Where are they in 2000? I say, oh, many of us don't even have all this. How they don't give me the job? Because the workers, what did I come to do? I sit down with your medical director, you talk. That's the level. So, you see a witch here, you see a chaplain here, talking. These are what make care hospitals like. Most of the rooms are 5-star. They are 5-star. I don't have time. I don't even do a lot of this. This somebody discussing prognosis. You see the way it's breaking the prognosis. I've never seen anyone bounce back from an autopsy before. Does the woman understand? He doesn't understand. So what is communication? Communication is a process by which we share information. The meaning of that information is very important. The feelings are shared by person through the exchange of verbal and non-verbal communication. That's book 755. Mark the word. Verbal and non-verbal message. You might think it just want to talk to patient. It's beyond that. What are your non-verbal communication? What are your non-verbal cues when you are passing the message across? There is one thing I like you to know. Well, I would say American, but I work with so many people. When you are with them and you sit down with them, you are already people by your non-verbal communication, by your body language. They know whether you are telling the truth or you don't tell. So you must be very sensitive about that. So that product is knows for patient what is being said. See being said explicitly, understanding. What does it imply? The message. And what is not said? What is not said is non-verbal. Because you don't want to see everything. So communication is like a medication, maybe because I'm a pharmacologist. And I came up with this. Maybe it's a medication, communication is a medication. You give too much medication, it's an overdose. You talk too much, and overdose, you are going to even kill the patient. If you talk too little, the medication is too little, you may not have effect. If you talk too little, your communication may be inadequate. And what is the result? Communication gap, lack of understanding, confusion, and conflict. That's how it starts. And it's not only about patients. It's in the way we will relate to people. And you learn all these things in leadership training. But communication is very, very challenging. So, what are the benefits of good communication? It creates relationship. You get endeared to you. The family gets endeared to you. When you are communicating, we give value to other person. And wow, I've been moving around different hospitals. I'm never going to see people. The added value. It reduces isolation. It just continue to wonder what is happening. They are able to gather information, you give them information, they enable expression of feelings. What is the meaning of this diagnosis? What is the meaning of this scenario? Where are you now? What do you intend to do? Then it helps to reduce uncertainty between the parties. So I think it's very important. Bad news and talk about bad news. What is bad news? Can anybody tell us anything about bad news? I want to move very fast because I have a lot to share. Because if you cannot, let me go first. Oh, I'm already there. We are talking my style. Please come back. What is bad news? Give some example. What you saw here was the definition. Well, the second question is give some examples. Examples. You are moving fast to people better giving you something. I see about it. Example of bad news. We are doctors, we are not this. Dead person. Okay, you are fine. But you do not make it to the patient himself. Any other one? Okay. How do you break it to somebody who has HIV? Huh? The next guy. A bad news, according to Ogun 1984, a bad news telling you that drastically and negatively alter the patient's view of it for our future. You are going to die. It alters your sign. And barriers to breaking in, effective communication. Not barrier to communication. We are talking about barrier to an effective communication. And these are some of the examples. Some of us feel incompetent about it because we were not taught in school. You need to acquire it as an adult education like this. Fear of causing pain. Now he has HIV. So I'm telling you, how will he feel? Because if you start tearing up, or if I even decide to tear me apart, how will I get it blamed? If the messenger is getting blamed, your consultant does not give you permission to go and break bad news, and you went to do it, and the patient is demoralized, and they are now being blamed for it. I remember the surgeon sent a patient to us several years ago, and was cancer of the pancreas. The patient was dying. The patient was not aware he was dying. She was dying. So I called back to him, please let us do an baby so that we prepare. The essence of prepare to what is going to be the children, don't waste your money and money. And as I was about breaking the bad news, in fact, the most senior consultant in heaven came to me and said, please, don't me. I was in dilemma. I'm supposed to do it. But the person who referred the patient to me said I should not pay to me. If I break me, I'm offended. Next time you will not send the patient to me. So you can imagine, so, see, when you are working in multidisciplinary, feeling that you have failed, managing people, you understand, shielding patients from distress. And I gave a good example of this yesterday, that when I was in India, the culture said that don't tell the patient what is wrong. You only tell the family. That's a different culture. You want to shield the patient. You tell him he will soon die. He might even die before he's dead. So that's what we do. Upward to show empathy. I hope I have time. I don't know how long I'll spend now. Upward to show empathy. In this business, or even the business of health, there are ways to manage so that you don't get yourself wrong. You can sympathize with the patient. You can empathize with the patient. You can show compassion with the patient. But it depends on which one you're supposed to do. But there's a particular one you need to do as health coverage. And you don't need to very time to do yourself. I hope that this life will get all the time. Honestly, to be candid with you, I've done a lot of work. This life that I'm presenting to you was I produced it in 2006. And I used it to train people in India. Not even in this environment. So the Taiwan is an old slide book, I don't know, but it's very, very good. I also use it in the school. I love teaching for the battle people. If I have time, I will differentiate between empathy, compassion, sympathy, what you're supposed to explain when you are. But we are talking about knowledge and skill. It's skill. You don't need to write anything down. If you enter your brain, enter your brain. You don't need it. It comes natural to us. We don't have it. It's human. Showing empathy is powerful if you don't understand empathy. What is empathy? Don't let us waste time. Because if I want to give you love, you must not waste time. Fear to get me involved expressing emotion. And somebody used one word for that. To express that. I don't understand English more. Because I didn't go to grammar school. I attended high school. But can somebody who goes to grammar school do that thing in another English for us? Fear to get too much involved to express emotion. I didn't give you another English. Yes. You have to get 2 months in about it. Just like you said, you went to UK. And one of the big boss said, no, he went to UK. We saw it, where it ends, but I cannot do it. It's fear, the emotion cannot carry it. Some people cannot stand where somebody is dying. Even if they run away, I witnessed our staff dying here. Our colleagues ran away. They left us alone. As if death is contaminated. And they are going to contaminate, get contaminated. Too little time to do it, but we must do it. So, I thought of this year. Conspiracy of silence. Family said, don't tell. Or else, they are going to take our vision from you. But when you look at fundamental man, who is supposed to know first and get prepared, whether you tell the patient or not, they themselves know that they are going. They themselves, they know that they are going. But because we did not tell them the truth, they are confused. There is confusion because we are not communicating. We have had several patients here. It's good, but we don't have time to teach it to them. We had a patient. The patient told the team that last night I had dinner with my late husband. You must have had that before. I had dinner with my late husband. In the spirit, because the other is not there. And we were communicating with the surgeon. Instead of them to call us, they called the psychiatrist. Oh my God, that psychiatrist are not here. They called the psychiatrist. And the psychiatrist decided to give cocktail. This one don't think Yahweh. Right, they will be more. Ìgbà wo lọ́wọ́ ti kú tó gbọ́kọ̀ jẹ dínà nàìjíríà. And by the time you got there to the award, the patient was sleeping like as if he's in coma. No, it's not like that. What is happening is real. It's already a spirit. He has already gone to the other side. He's already seen the families. He's already seen the ancestors, except we believe in ancestors. Christians may not believe in ancestors. I don't know whether Christians believe in ancestors. But Christians may not believe in ancestors. It's a portion to die. And when you die, it's end. But Yoruba believe in ancestors. And that is why you get about today. They are not foolish, they are very intelligent. They are well. And when we are young, I don't know whether you see get that paradox now. When we are young, you see a small child combusting, went to unconsciousness and died. And wait till that child come, and the child comes back. Oh, I was somewhere. I wanted to cross the river. And my grandmother said, Kai, what are you going to do? Go back. We have our own spirituality, which other religion push people. And that's what makes us vulnerable now. Because we don't understand the things of the spirit. We only understand the things of religion that was brought from kingdom in Christ. That's our problem. We are very small, black, very, very small. I don't want to start anything because people will not do it. But that's how you understand all that. So, what is our family barrier? Who wrote this paper? Batch 2012. You can read it. It's not different from what I've been saying. This is evidence publishing, peer reviewed journal, but I was saying, I saw it. That's another form of communication. So when you are going to practice in India tomorrow, don't prepare. Or if you prepare, you are your own. You have validated the culture and norms of the society. And anything palliative care, you must adapt to a particular culture and values. It's very important. You must know it. You must know it. So what type of awareness? In time, close awareness, where the patient does not recognize, or deny. We have seen so many people deny, no, we are not going to die. But everyone around knows, but is denying it. What is the danger? It's very dangerous. Very, very dangerous. Everybody knows you are passing. I'm saying you are not passing. The spirit is in the body. The way you use your body, that's how you live. The body is a container. The body is not you. The spirit is inside. When the body is damaged, the spirit gets out. So we are like a candle. If you burn yourself up, it's okay. But if you burn your candle both ways, you are going to expire fast. And I just know that people when they start burning themselves up and down. That's why they do themselves and they go. So your body will tell you that the spirit wants to get out. But people may be in coma. I've seen the US. Coma, 10 years, young girl. And they are still spending millions because the spirit are called on. They will not allow them to go, but we must do. So the body will tell you. And everybody knows that you are doing it. And because of wants to be religious, he said, no, I reject it. It is written. I shall not die. I shall live. And what happens? And they said, what are the only people said? Ogun, níṣẹ́jú àyà, orí bọ́dé o. Because the thing is like this, we are here, that thing is here. If you make that mistake, by Jabo, they said he entered tunnel. And when you enter tunnel, he started running away. I don't know where he run to. Through lights. And that is there. Go and read near-death experience. Read it, it is very interesting. There may be a lot of lights. There may be a lot of lights. But you see some significant stories that are the same, which none of the holy books will tell you. What will happen when it happens? Don't give a man a shot on the head. You say you don't need to die, don't die. And dies immediately. That is the process. So, the body will tell them, but they will say, no, you are not going to die. But what is my fear? Because I'm a medical physician. The essence is a warning. If one die of chronic disease that is not too much, it gives you opportunity to prepare ahead. Because all of us believe there is God there. We want to work with. Okay, I forgive you. Please forgive me. I pay my dues. I pay my debt. Because you can't believe that if you owe debt, you are not going to cross. If you find me saying this a black doctor, it is the outbreak against me. You are not going to get there. Because only the clean people that get there. So it's an opportunity for you to prepare. And that is your responsibility. Because every human being is in 3 dimensions: the body, the mind, and the spirit. So we are taking care of the body. If you enjoy it, you take care of the body. But what is going on in the dimension test? And you must prepare their spirit so that when they are free, they will tell you, look, I'm okay, I've seen, I've conquered enough, I'm ready to go, I've done enough. Even those people who have out of body experience, when you call them back, they will say, why are you so bad like this now? You mean you bring me back to Nigeria or come me again when I was enjoying where I was? And you be beating them, say I'm God. Then you join you. It's a different environment. So the body will tell you, I know whatever I'm angry. So better awareness, patients suspect what others do and attempt to confirm or negate it. Confirm it, okay, don't think that they are or negate it, so I reject it. Mutual patient awareness, everyone knows that patient is there, but we tend to each other and we do not know. Even we are the same. Those of us who are very religious, when you see the patient, sister, tell the patient, it is well. It is well in Jesus' name. Inside well, it is well, not me. It is well. Let's learn to communicate and how to say it better in a way that it. But you cannot do it once. You do it better. And it seems better. Open awareness. Patients have relatives and make them see them and speak and act accordingly. We will post to this people. They are ready. And that's why people look at my life, they have to this guy live this life. I don't have because I like seeing the world. I see the world. And what am I doing? I'm preparing myself. I've entered play with so many people I don't even want to believe that I cannot even see them. And when I say I've seen the world, the grace of God, not God, I've seen the world, very much. And at the end of the day, I want to say calmly, quietly, without pain. I say, no, I've seen the world. It's not like I'm telling me something is happening in Canada, something happening in China. I've seen the world. I've conquered. I've worked with it. And when you live your life like that, you are not invested in any way. Accumulating it's what is it's what values you have. Then it makes like a simple. That's my philosophy. So I come back to break bad news now. Most people want to do, some don't want to do. When you break the bad news, the social relationship, you mentioned it, with you and the patient, and also the family. Some family become our friends. We become family to them. The foster collaboration in planning. It permits patients and family to plan and hope. Because you have to plan ahead and to cope with the problem. I think they are supposed to be fun here. And when that thing gets hot, don't have to people who small farm. Yeah. So you can roll down. Yes. Somebody mentioned spikes yesterday. And I was very impressed about what happened yesterday. There's a lot of lecture you do not even get to. And people have the knowledge and the skill. And that was why we changed this training from what we used to do. In the past, what we used like that. But this time around, we decided that we must socially construct life. In learning theory, we call it social constructivist learning. You have been doing it. You know you have been doing it. But you want to do it in a standard way. And that is why we construct life ourselves. That is fine. I know many of us have it, and you also use it. But let me know what the more we have a good setting. Like in the ICU I was telling you about, we have a small area, and we know we identify who people we are. Setting up quiet, having conducive, so that there is no distraction. And the way we set up our work in this place is not supposed to be. Where the Madam Major, the General Overseer of the world, is staying, that's the only place where we can talk to the patient quiet. But usually the Madam Chigo of the world is there, you cannot afford the General Director. They make you one. And it's so awkward. We have to bring them to our department inside quarters to have a good setting. So for those of you who become CFP picture, make sure you have all those things. Side, and then side arm, well at all, silent room, and all those stuff. Perception, we said it. How serious. You have just diagnosed the HIV. And just like I tell you, the body will work, no matter what. The body will work. Okay, you already have the diagnosis. Then you ask the patient, what do you think is actually happening? I'm always tired. I think I'm losing weight recently. I think I'm sweating in the night. I think these are getting information. And at a smart healthcare operation, you are putting those things together. 1 + 1 make 2 + 3 make 5. She has already presented it. It's just for you to add something together and come with it. You know? So invitation for patient to give information, and that's what makes it easy for the patient to understand. Okay, if you have these kind of symptoms, you have been listening to the watching TV, what does it mean? You already preparing to get to accept the news. Thinking is HIV. So, do not have to discuss further. You must have the medical facts. You are studying the case notes. And don't talk medical jargons in a very explicit, simple way. Now, explore the emotion and empathize patient response. Some of them will be emotional and start crying. You must be ready for it. I remember when I went to do my palliative education and practice, easy, trying to have medical school. They give us patients. And there are so many people who also go for training like this. And when it was told, they say, Father June, speak to your patient. And the man started crying, doctors talking up, smiling, talking, and now I'm guy. What am I going to do here? Already have my training, palliative place. So the first thing that came to my mind, I just put some napkins. I gave it. I said, can you please? She did it. Started to talk. And I realized that it's difficult for me to break down. And then it was difficult for me to break down. Then I now come out in my own sense. What can I do? Which kind of education? I realized that the last soul that I ever bring anyone in is spirituality, not religion. Personal relationship with God. So everybody says, those who worship God in spirit. Spirituality level. And human growth. And human started to lie. You believe in God. Somehow, God has never worshipped. He does not even believe anything. Started crying and crying. So I said, well, I'm formulating the gap now with stuff. And I said, aside. And he will give you reflections about what you have done. And somebody said, tonight was so calm. When God made me a napkin, give it to the woman to wipe her pain. No, the way was to got the sweat because I have the spirit and the knowledge. But little did I know that all those patients, they are actors. That's how they play. Not what they play here. They are actors. They can beg you. They can make you fail. It's not that. That's another thing. But they do that. That's not how you can do. Then you can't always know this to the organization. And that's what we are saying. So after that, we strategize together and take time. Man, what are we discuss? Because we may not be anything this year already. Then you summarize. Then we meet next time. It's very simple. That's how we do. So system, you must say the same. How much the patient wants to know. Then you share the information, disclose, respond to the emotion, practically plan and follow up. Very simple. Every one of us can do that. How everybody knows. We use it in HIV, we use it in cancer patient. These are the format. You have HIV, no, it's not me, you're not fighting. Anger, maybe that useless, waka man, worry, like this people. Or the doctor to identify on time. And it's true, and waka is hard by giving about it. Then they go to depression. Sometimes they accept, but it doesn't flow like this. They may accept today and bring in anger tomorrow. So you must know where you meet them. You can meet them any of those. So that theory is very, very good. Not only for cancer patient, but you can do for any of the patient. Please keep this. Next time. Denial, disbelief. They have been telling me that time, I said, no, not my body. First one, Anger. Let's talk. Depression. This is a small child in India. Can see depression. Not only in her, depression even in the mother. Because of body of the disease. Reassurance, that acceptance, it is you that are going to reassure and make them overcome. So communication constraints, religions and brothers, different people, you must have cultivate habit of active listening. You use open-ended question. I don't need to go into that. You know what close-ended question. You know what open-ended question is. Reflective statement. Clarification. Okay, you read this from Apple before that. Just like them and know that they are coming there. Summary. You validate their fears. You reassure them. You show them that you are present with them. Sometimes you do silent. You don't talk too much. And about what? Read them. None of our people are very important. That's what I said. Body language. Let your shoulder relax. Let your hand on your knee. Eye contact. Same level. You can touch their hand to show your presence. But here, you have to be very careful. Because if you go and touch Alaja's hands, what do they call Alamu? So you must know the culture, who to touch and who not to touch. But in some places, you are allowed to touch. It's an effort. Show that you are there. So that you are identified. It's not that you want to have any secret. You relax them, you leave them. So non-verbal listening skill, keep eye contact, pay attention, sit near the patient, and relax the position, that keep safe, outside, it along, carry your water along, encourage makes more free, makes touch that another those things you are talking about. Open question, how what did that mean? So you open up, not a closed question. Facilitate, pause, silent, nodding, okay, smiling. Oh, tell me more about it. Repetition, you mean this, you mean that. Clarify ambiguous thing. Upward up. Handling time and interpretation. No faster. Empathy. What do you understand by the term empathy? Give some example of when you as a dog are empathy with the patient. How do you feel when you are willing to identify and aware to identify what the patient and what the needs to do? Empathy is very important. I would like to, I want to have more friend if I can dissolve with you, do some stick having teeth about empathy. Next time. Okay, this is the definition. Okay, I told you I got this slide about go back. 2002, I know go through. Empathy is what I'm going to do. Your feelings. If that very visa, then God require that very visa. Simple technique, observe the emotion of the person. Empathy is because like you seem to depress. You seem to be angry with the doctor. You seem it must have been very distressing to you. You know that you undergo all those chemotherapy and radiotherapy and you see you still here. That's how you can. This must have been awful for you. You mind your language. You know how to communicate. So apathy, sympathy, empathy. How many times? No. That is normal. Okay. Okay, go back. That's normal. Affects. But those who go to grammar school, you know what affect is. Yeah, I know. I went to high school. But we talk about sympathy. We are sympathetic to the patient's cause. But we are not trained to be sympathetic about patient. Especially with the kind of patient that is. Because you are too sympathetic about the patient. You are going to carry their body on yourself And when you go home, you translate to your husband or wife and children. You know it. Because you are going to start. You cannot even count the number of people I've seen in my life. I went to medical school 5 years. I must have seen them. I graduated in 1987 and I've seen them for a can't. So there's no issue being you are being sympathetic. Wọ́n á sọ pé wọ́n yà wá ojú àti dá. Ebi ẹ̀ láti dá gbọ́ yà lórí kí ọ̀sẹ̀. So no need to be sympathetic. Compassion to some extent. Apathy you cannot do. Empathy, that is what you should best with. And I want to tell the small story if you can for you to be able to clarify it. I will tell you. A man was going. It was during 1970s. And he looked into the well. If there is water in the well, he realized that there is no water in the well. But as he bent down, the last 50 naira or 20 naira that was in him fell into the well. I think that time 20 naira or 50 naira was really very good money. Maybe the exchange was $1 to $1. So because if 1,000 enter well today, you don't even look at it. But because of that small money, the man said, wow, if the money there now, he jump into the well to give that money. And you'll be surprised, some people jump into the well to give 1,000 naira as bad as it is. So when he entered the well, he picked the money back alright, but I think much money. Now for him to come out is the problem. The problem is to run at that 50 or 20 naira. So he remained inside. And he has no choice. I have problems there. And somebody was coming, it's making noise inside the well. And he said, it's big. What happened inside the well? My last 20 naira fell down, and I have to pick it. He said, okay. Over the law. Another one had the money. And what to do? Sorry, Baba Langweka, Machu, we did not believe no. And what am I doing to do? It's one or two like him. He jumped into the well. To go and carry him out of the well. Two people. And the two of them now shouting, hey, we are out here, please come and take us out of the well. And this one said, after two people jump, you fight. After two people jump, because of what? Because of president, you jump into the well. You go between you. And the guy went and looked at put this rope there and carry them and support each other. It's a very simple story, but a very serious one that have many. Go back to that one. That's what I've done this time. The first one said, only good English. Because of 20 times, I want to kill yourself. The guy pass. The other one, very sympathetic, Allah was Samaritan woman. And that is the point. Don't be Allah was Samaritan on the world. What you empathy. Putting yourself in that person's shoe. We have to say shoe. Assuming this thing happens to me, what can I do? And that is why Palliative can only do one way. Because we go any lengths for a patient account. Empathy. We go any lengths and we have so many stories. One story before I left. There was this man, very rich. He was a big engineer in Lagos. In fact, he was the engineer who was constructed 1004 in Lagos. You know what 1004 is? For you to know how rich that engineer. And they gave me 2 flats in 1004. And when money comes, the guys are there in the video. Nobody is being away. They are all over. Started carrying police away. The Jabo could not perform it. The Jabo disappeared and left. And they moved to UK. So this man was doing his life the way he was doing it. Drinking and all those things. Family did not really have some problem. One day he slept. His cigarette lit the room and the whole flat went up. The man became nothing. He will become nothing. Because I don't really get his suffer. You can't escape it. The law of karma is here. So by the time he was dying, there was nobody with him. His wife is in UK, his daughters are in UK, he don't even bother about it. And he was dying of cancer of prostate here, and he was there. And for you to know how far he went, who are those people surrounding him? No, they don't drive in the UK, children are in the UK. They are poor, they never sleep for long. But before you wife, they do it. No, that man is a terror. You want this man to get to heaven. Their boss will tell you, I forgive you to forgive you. You have to forgive this. The woman came from UK. With this board here. He brought her down. If you can't tell you will not believe what we have done. You are not matchmaking HIV patients. They want all you are giving them husband. All these things you cannot see. Palliative care has no limitation. It's an innovation. Depends on how much you can innovate. It's very, very interesting thing. None of us cannot do. And that is why we are here for here. You can't tell people that you can stay down here. Director of everything. They are here, they are retired, they are working here, voluntary. The president is serious, they were director of government services. We started this thing long ago. We did not join it because we are sowing. You must sow before you reap. But the only people that not say it when you sow, you reap. Just need to sow. When the harvest is coming, you don't know. But we are sowing, not for ourselves, but even for our children. So the woman, they did what we're supposed to do. I forgive you. You forgive me. You want to say, and once started making arrangement, we are going to be searching food. He doesn't have a house. So the family to share in their family traditional home. You can imagine somebody who has two class and people have in the end. That was what he saw. That was really at the end of the day. And of course, the man has to go. The children did not come home. He does that. He does everything. I hope he makes everything. Those sequence is also about foundation. So I want to rest my case. Communication, therefore, involves not only sharing information, but also emotional support and care. So many things. Need to develop communication in interpersonal skills. Facilitate the process with patients rather than engaging in blocking and distancing tactics that hinder effective communication. The skill involves active listening, open questioning, reflection, promote better communication, and encourage empathy and unity. Thank you so much. I get to so I have what I need. So there's slide there. No. There are some presentation you cannot gloss over. If you gloss over, you are going to miss the information here. The way I explain empathy, sympathy, sympathetic for you may not see it in textbooks like that. You understand? And what we are doing is to give you knowledge, skill, that you don't even need to read it again. Because you don't read it. It's part of us. So we're going to give agreement. I'm going to be very fast about it. I'm not going to teach. I'm just browse. So what have you? Model of grief, types of grief, below types of grief. What are the challenges? Pathological grief. Do not forget what pathological grief is all about. In 10 to 15%, you have patients who have had pathological grief as a result of being depressed, loss of child, or loss of their loved one. The strategy to combat it was the CPH. I will use you like I'm not telling you. Lots of them. You see that you can see it on the face. Disaster. You can face many things, emotional, anger, tearing, it's a very bad. It's a very bad. As to that definition, it's a loss. Response to loss. Particularly loss of someone who has just died, born, you have affection for, has emotional, physical, cognitive, behavioral, cultural, spiritual, responses and implications. That's the definition. And as a result of that, there is always a stress response to bereavement involving psychological and physiological. Bereavement refers to the state of loss and grief. So you see the difference now. Bereavement is different from grief. Now, when you talk of grief, do not that it's because you lost loved one that you are grieving. We grieve after something extreme. I remember our dog died, and we need to bury the dog. I have to carry all my children and put them inside car to go and witness the burial. It looks easy, but I want the inclusion. They are not doing the inclusion. And 1 week after, in that house, the children could not eat. That's the problem. Grieving. My friend, if you misplace or lost your food, well, you will grieve for some days. So now you are a human being, you will grieve. That's as bad as what you mean. So you can imagine what your patient is passing. So there are so many theories that have been formulated. Evidence, swap, shock, disbelief, developing awareness. That's trying to rationalize restitution, resolving loss, idealization, and the outcome is to survive. That is so theory. Other theory, overall, we have used this one severally. When we are grieving, you see all this. Another theory, called the 1980, numbness, shining, searching for the lost one. No, take me to the mortuary and see. No, he has not died. I know it's alive. This organization and then disappear. They are not connected again. You can see that you need this because you are going to meet the family and give them immediate care and support. So once that knows and see, the organization of yourself, slowly and slowly, loss-oriented activity related to death, crime, yearning, sadness, denial, dwelling on sacrifices of death will have been prevented, avoiding installation. Crying nowadays is not most of the very good genuine. Because I realize that when we are looking for funeral now, the higher town cry, they will come and cry as if the government has not seen before. That's not restoration, restoration project associated with secondary industry like regards to lifestyle, mixing relationship to the king, adapting to new rule. I believe you understand. Model, now 2008, accept the reality of loss, You must help working along with them through the being and the faith. Adjust the line that is saying. Adjust the line that is saying is a very, very important. But don't let all the say that line continue if you set aside. People will let them speak all my job. Don't take care. Line continue. So you must analyze that. But there's a connection to the sin while moving on with life. That one is true, but I'm not moving with it. That's complete. Anticipatory grief. Anticipatory grief, when it is anticipation of grief. The patient is anticipating his own death. He's already grieving for those people who's going to leave behind. He's already grieving for his own life. Just like you are grieving for your food and blood. But anticipating grief is both ways. If you are very close to the speaker, I know how God knows, I know the things of the speaker. We prepare here to faith for anarchy to the website for the husband to eat. That's what already grief. And I think a lot of things that we are seeing here and done grief. Self-righteous grief, not avoided by society. Death of a friend, loss of a friend, loss of a waiting for society. It's your own enemy. Don't mind. But at the end of the day, if you see somebody who has a disenfranchised grief, watch out. Because when the pathological grief will happen, only that will. So identify him and try to help them out of it. So instead of grief, I'm not wasting time. Initial shock, pangs of grief, despair, and I just fail. Common emotion, developing relationship with them, emotionally reeducate the deceased, important or not set up in a grief life. Very well. Complicated grief, example for you to see very complicated grief. Especially pathological grief. A grief that is prolonged. You see symptoms for at least 6 months and affect that's pathological. From other criteria that affect their mental, physical, impairment, symptoms, amount of time next time. So grief, we talk a lot about grief. Normal grief, somatic symptoms, and you do not sleep, you cannot sleep, memory loss, repair. What can you say? I don't understand. I don't even know where you say it. Social withdrawal, sense of presence of the cell, they can feel him in the room. Auditory or visual hallucination. Complicated work, journey for the disease. Trouble accepting the inability to trust others. High degree of bitterness, difficulty forming a relationship, feeling like the same thing or meaningless. And of course, this is our role. Bereavement support. And I must have. Please, when your patient asks us, we stay with the patient family for the next 1 year. And that's why it says patient and family center. Patient die, we be with the family for the next 1 year. As a matter of fact, we are our last respect. We are always at the better. We say, we strive for you, and we give you that respect. And family always, that is where volunteers no, we do things like the center is really in Lagos, they are coming up because they are not volunteer. And they decided you must have hospitals in Lagos and they are spending not less than 500 because of the stress how their fathers suffer during that period. So believe it. The stress of losing a loved one is a universal stress, potentially dangerous to health. Associated with high mortality, just unfortunately, ìyàwó náà ti tẹ̀lé ìgbàgbà kùfà. A set of shock is being denied. That is the idea of maintenance. Next one. So what do you do? Emotional support. You must have a skill before you can support. You must know what it's all about. And what we are telling you is those are our experiences on how to support them. You must create the support group. And of course, pharmacotherapy, SSL, exactly as a thing. the strategy to do it, the strategy to do it, ability of adults, otherwise members of the society, who are exposed to an isolated, disruptive event, so that they from prohibition, that very situation, is to maintain relatively stable, healthy level of psychological and physical health. You asking them to get to that, as well as the capacity for generating experiences and to develop positive health. Thank you, ladies and gentlemen.
Dr. F. Oyebola's presentation, which I really commented. And when talking about communication skills, barrier communication, just there. So thank you so much. Distinguished doctors, pharmacists present, nurses, and other. This opportunity to come and just present 5 minutes of our brand to you. It's actually just a unique approach towards the management of patients with osteoarthritis. And from what has been mentioned earlier, I have come to understand that this department is all about looking for how to alleviate the pain from patients, which is in a way or two aligned and in line with the brand I came to talk about very briefly, and I'm sure that they have shared our leaflets to you as well. So just please permit me. Okay. It's working.
Was the batteries?
It's weak.
That is weak. What type of battery is this?
So very quickly, I mentioned we just want to introduce to you from the staples of LB Pharma, marketers of the anti-malaria, Amatrexone gel, Ibasmine, Sinos, TN, Amala, and a host of others. So the beauty of it is LB Pharmaceuticals thought it wise to delve into the nutraceutical arm which is why we have this particular product that we want to talk about today. We have it's called the Derived Nutraceutical Team, which is where we belong to. And I mentioned it's women. At this point, I want to understand that probably the tendency to carry the fetus, and then the weight of the fetus is resting on the hip and the knee, and all of those things. And that is why we have the fact over there. And on the slide, I actually have a pictorial representation of osteoarthritis, where you have a healthy joint and also an inflamed joint as well. So here I have the predisposing factors. We already mentioned why we're talking about prevalence. It's actually age related. It's also we also have the osteoarthritis related factor, which is due to obesity, where we have some of young patients that are overweight and they are not trying as much as possible to manage their weight over time. And it can also be genetically induced as well. So the next slide is just talking about the clinical presentation of the osteoarthritis. Like I mentioned, this department is unique when it comes to alleviating pain, managing pain, which I believe this brand can also come into play in the department, because the brand is positioned to the brand is positioned to help manage pain, and also prevent further degradation of the cartilages as well. And the clinical presentation, most of the time, your patients complain about pain and stiffness around the joint. Sometimes they mention that they hear this cracking sound as well over time, and it commonly affects the hip, the knee, and some other joints, as the case may be. And so the treatment objective is majorly to prevent or control joint damage, to prevent loss of function, to decrease pain, and to maintain and improve the patient's quality of life, which is one of the 4 key things Doctor mentioned and I captured. And also to avoid and minimize adverse effects of treatment. And Management of osteoarthritis, there are actually some modalities. It can be some injectables, injectables, or oral medication, and of course, your patients some use canes, walking sticks, and the like. And also style modification come into play. So these are more like the modalities of management. Of course, I'm coming to be professionals, and you must ask me where are your facts. So on the slide is just a study showing how effective glucosamine, sulfate, and chondroitin combination is when it comes to managing patients with osteoarthritis, preventing further degradation of the cartilages around the joint, and also inhibit generative enzymes, stimulate the metabolism of chondrocytes and synoviocytes as well. So the study was actually done in 2020, but the study was more like a review of major studies that were done in 1980 and 1994. So it was actually a review, and the first study was done in 1980 was by Ogun and Dept, where they had a controlled clinical trial which involved 30 inpatients with chronic osteoarthritis and were administered IM glucosamine sulfate. And of course, the author concluded in that particular study that pure glucosamine sulfate effectively managed the symptoms of osteoarthritis and also improved articular function. And then the second study there is that of Rachel in 1994 in Germany, which was also a randomized placebo-controlled double-blind study. And 155 patients were involved and were administered glucosamine sulfate. 155 patients were involved, but were categorized into groups where some received the placebo, that's 0.9% saline, while the other group received the glucosamine sulfate. And from the study, thank you, sir. And from the study, the author was able to conclude that administration of glucosamine sulfate ion significantly improved symptoms of knee osteoarthritis. Okay. So that's the study I'm talking about. And in the study, this was actually the dosage regimen. The first study was what was administered was about 400 milligrams per day, and it was IM, and the duration was for 7 days. As well as the second study, 800 milligrams was administered per week for 6 weeks as well. Okay. So I mentioned a glucosamine converting combination is one unique constituent when it comes to diamide joint activo. Another unique constituent we have there is sodium iodinate, where it has anti-inflammatory and anti-anoseptic properties. We have the omega-3 fatty acids present as well to help improve joint pain and swelling in cases of arthritis. And it also helps relieve morning stiffness and duration of pain. So that was why I mentioned earlier that this brand is also much more in line and respecting the rules and the objective of this particular department. And of course, if we have curcumin, curcumin is another active ingredient in joint activo. In fact, curcumin is actually the major constituent that provides this anti-inflammatory property. And here is just a study from Daneshwa in the year 2019, telling us about the safety and efficacy of curcumin as against diclofenac. So here, the study is not trying to talk down diclofenac. It's just saying it is a safer and efficacious approach, because from the study, about 139 people were involved in the study. He grouped them to 60 and 69 in 2 groups and administered some diclofenac to some group as well as curcumin to the other group. And after 2 weeks or thereabouts, the patients that are receiving curcumin actually showed similar improvement as those that were also receiving the diclofenac. However, the added advantage of that of curcumin is there were no ulceration, duodenal ulcerations, and all of that. So that is the study showing the efficacy and the safety of curcumin with respect to pain relief as well. Okay, of course, we understand how important vitamin D is when it comes to bone health. So, Dept activo contains vitamin D3 as well. So, the other slide is just more like explaining the role Dept activo plays. And in the flyers that are given to you, you would see a detailed information on the role Dept activo plays. When it comes to joint support and mobility, Dept joint activo is the go-to brand. When it comes to bone and joint health, Dept joint activo is the go-to brand due to the constituent like zinc, glucosamine, collagen peptides, and the like. When it comes to anti-inflammatory benefits, Dept joint activo is also the go-to brand due to Oswella sterata I mentioned earlier that also has anti-inflammatory properties. And then when it comes to antioxidant benefits as well, we have the mostly, we have the copper, we have superoxide dismutase, and curcumin, which is also a potent antioxidant. So it's actually a daily supplement, a daily vitamin that every adult that is desiring nutritional supplement can take. And it's also an antiplant when it comes to management of, I mentioned, severe osteoarthritis cases of your patients. And you can recommend it for athletes or patients that are also overweight, people over the age of 35, and it is just one soft gel daily. And a soft gel pack comes, soft gel comes at the rate of £1 only, which I believe, which brings about 4,500 for a pack of 30, a month supply. So I appreciate distinguished professionals that you choose the joint brand, joint Activo brand that work and choose Therapite joint Activo. Thank you so much for your time.
That's the banana. From Pharma, joint Activo. For our patient with osteoarthritis. Yeah. Okay.
Yes. If not, yes, for the benefit of this program and it's a huge opportunity. It's actually 4,500. But you can get that 4,000 naira if you get it. Yeah, sorry, man, now.
So let's enjoy our fruit break. For 5 minutes.
Well, let me buy this one.